Good day. My name is Michelle Lavander. I'm the founding director of the USC Center for Health Journalism. Thank you for joining us for our Health Matters webinar, reporting on Alzheimer's unequal toll in communities of color. An Alzheimer's diagnosis can be a devastating blow for any family, but this disease is hitting communities of color especially hard. African Americans are more likely to develop Alzheimer's and yet less likely to be diagnosed until much later. Even with a diagnosis, Black Americans are less likely to get high-quality care, medication, and participation in cutting-edge trials. Similar challenges confront other communities of color. As we'll hear from our panelists, families end up having to navigate healthcare systems marked by layers of bias and discrimination. Their concerns and pleas are often dismissed or disbelieved, and those who end up caring for their loved ones often end up making huge sacrifices, putting lives on hold and making do with few resources and supports. There's an urgency to all this as well, with cases of Alzheimer's among Black Americans projected to increase fourfold by 2060. Today, we'll hear three different perspectives on how Alzheimer's disproportionately impacts communities of color. We'll explore how health systems can more effectively engage and serve overlooked communities. And we'll hear about how journalists can tell these stories with sensitivity and compassion. Here to share their expertise with us, we're honored to hear from Kat Stafford, the Global Race and Justice Editor at Reuters. At Reuters, in her editing role, she works to ensure that stories include a range of perspectives. She also continues to report. Stafford joined Reuters in September. Previously, she was a national investigative writer and global investigations correspondent at the AP, focused on race and inequity. At AP, she reported on how structural racism has fueled inequity across America. And if you haven't come across it already, we highly recommend her masterful storytelling in her recent feature, A Lifetime of Racism Makes Alzheimer's More Common in Black Americans. We'll also hear from Petra Niles, a gerontologist and current senior manager of African American services at Alzheimer's Los Angeles. She provides ongoing education and outreach in the LA area, including workshops tailored to the African American community. Stephanie Monroe, meanwhile, is a vice president and senior advisor of health equity and access at Us Against Alzheimer's, a national advocacy organization based in Washington, D.C. She also directs African Americans Against Alzheimer's, which was founded in 2013 to respond to Alzheimer's disease's disparate impact on African Americans. This webinar is made possible thanks to the generous support of the Commonwealth Fund, the National Institute for Healthcare Management Foundation, and the California Endowment. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format today. We'll be hearing from our speakers first, and then we'll turn it over to our audience for your questions. Feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel, and you can also write us if you're experiencing technical problems. Now let's get underway. Stephanie, can you help provide us with a national view of this crisis? Why aren't those disparities getting more attention? And what are some of the policies that could make a difference?
Well, thank you very much, and thank you for the opportunity to present today. As in the introduction, I have been working on Alzheimer's disease and having a greater understanding of health disparities, barriers to diagnosis and treatment, lack of attention and conversation about things we can be doing to prevent Alzheimer's disease, and then ensuring that minoritized populations, which have some of the highest prevalence in Alzheimer's, have access to treatments, that we have access to accurate and timely diagnosis, and also that we have access to family opportunities to participate in really good caregiving. When I started working at Us Against Alzheimer's in 2010, I had no idea that my family had been and would be impacted. As 3 years later, my father was diagnosed with Alzheimer's disease and has been living with this disease for the last 10 years. As many will say, if one person in the family has Alzheimer's disease, everyone in the family has Alzheimer's disease. I will say he's doing very well. As you'll see in Alzheimer's, many people will have different plateaus. And so he's been doing very well now for at least the last 3 or 4 years. and then he might have a different change, and then the memory and other things will sort of replumb themselves. So Alzheimer's is a very unique disease and impacts the brain, which I would say is probably the least explored and understood organ in the entire body. It's the engine for everything. And so when we talk about Alzheimer's, we often just think of it as memory loss. But it affects everything. It affects our breathing. It affects our ability to remember how to swallow. So it's not just remembering a picture or a name or a place that you might locally travel to, but really how to let the body function in the way the body is intended to function. It normally progresses in most communities, I think somewhat rapidly. In the Black community, it's a slower progression, which is a good and a bad thing. We often, as you said, diagnose later when the medicines that are available up until recently would not be as effective. What we are seeing is that Alzheimer's disease impacts African Americans at least twice the rate of non-Hispanic white Americans, and that Latino Americans seem to be getting it at least 1.5 times the rate of non-Hispanic white. There's not a lot understood in terms of exactly why that is, although we are learning more. We know that we often see Alzheimer's disease in families which have vascular issues, heart disease, cardiovascular issues, diabetes, obesity, things of that nature seem to be a better predictor, I guess, or of people who may go on later to develop Alzheimer's disease. We also see that families, especially in Black and Latino, when we also, have the biology, but also when you may not see that strong biology, but you have social and structural determinants of health that make Alzheimer's something that, frankly, you can see on a map by zip code in certain areas, depending on what's going on in that area with educational level and quality of education, the environment, food and good nutrition, clean environments, opportunities to exercise. All of these things seem to be factoring into communities in terms of whether they will likely have higher prevalence of Alzheimer's disease or less. If we had time and if people are interested, I'd be happy to show you a map which we've created at Us Against Alzheimer's, which actually shows where the prevalence is in the United States. And perhaps not surprisingly, we certainly see higher prevalence along what's known as the stroke belt and along the bottom part of the United States from Texas up to, say, New York. Very high prevalence of Alzheimer's disease in those particular communities. So we know the biology matters, we know the genetics matter, and now we're learning more and more about where you live and grow and work. That seems to matter as well. So as I wanted to proceed, a lot of people, they don't really understand, as I said, Alzheimer's disease. It is the most common type of dementia. If you consider Alzheimer's or you consider dementia as an umbrella of frontal temporal Lewy bodies, Alzheimer's, vascular dementia, dementia that we may see in people who have Parkinson's, those are different types of dementia. About 75% of all dementias that we see appear to be of an Alzheimer's type. And what that means is that when we look at medications, when we look at how it presents itself and the pathology for Alzheimer's disease, it will be different than some of the other ones. And so our strategies need to be different. And therefore, the way that we diagnose and treat and project how people will live and survive and hopefully thrive with these different types of dementia depends on how it's being characterized. It does increase with age, but it is not a normal part of aging. Some would say that some memory loss is normal, but memory loss that affects your activities of daily living, walking, eating, toileting, things of that nature, certainly not normal. And when we begin to see those at the earliest stage, it's important to talk to a medical professional because it may be Alzheimer's, it also may be other things, a medication problem, it could be multiple strokes, there are other conditions, and so you want to rule out and rule in what we are seeing. It is the only disease in the United States that are of the top 7 that have no cure. We have seen new treatments come online this last 2 years, which are exciting treatments in that they appear to slow the progression of Alzheimer's disease, hopefully to give time for better treatments to come on, but also to allow families to have more time experiencing the love of their loved one at a particular stage, and also then to plan for the future. But if we looked at all of the diseases in America, those that are in the top 10 in terms of what's killing people, it is the only one which is on the rise, about 145% per year. We've seen lower rates in terms of breast cancer, prostate, heart disease, stroke, HIV, but again, Alzheimer's, which is an epidemic proportion in the U.S., contributing to the deaths of nearly 6.7 million people eventually. Since there is no cure, it's very significant. We know that 1 in 9 adults over the age of 65 will develop Alzheimer's. 1 in 3 who are over 85. 2/3 of those individuals are women, and also women also are 60% of those who end up being the caregivers. So it's really a double whammy. When we look at the racial differences in Alzheimer's disease, we see that 19% of the people with Alzheimer's are African American, 14% are Latino American, and then we have 10% that are non-Hispanic white. And this is important when you look at the fact that Black Americans in particular are about 13% of the population, but close to 20% of those with Alzheimer's disease. So we're seeing these disparities, which we need to address. It's having a huge economic impact in terms of the medical system, but actually most of these costs are indirect costs that are being borne by family members, costs that are being borne for caregiving, whether it's people losing productivity, leaving the workforce in their 50s, dual earners who are having to sacrifice one income to have a person remain at home, and then the unreimbursable cost of having a loved one in potentially independent living with caregiving, and then potentially assisted living. As you know, we don't have a really good formal long-term care policy in the United States. We don't have paid family medical leave in most states in America. These are the kinds of policies that could really help. I can tell you that in my family alone, my dad is 86 with Alzheimer's. My mom is 90. Both of them have challenges. They're living outside of the home. Our family is paying about $15,000 a month for care and a place for them to reside with no reimbursement. And so this is really a significant issue. And we're very concerned that families who don't have the ability to pull together these resources may not be making decisions that are in the best interest for their loved ones. By 2030, as you mentioned, this is going to just grow as America is aging and browning. We predict that 40% of people who have Alzheimer's disease will be Black Americans or Latinos. These communities are already burdened because of comorbidities that we see in these particular communities. And so when we layer Alzheimer's on top of that, it really becomes a significant challenge. So there's a lot more I could say. I think I'll let one of my other colleagues chime in, and happy to answer questions later on.
Thank you so much, Stephanie. And we have already heard from somebody asking to see your map, so maybe we'll circle back to that on that. I too really want to see it. And okay. And so now I'd like to turn to you, Petra. Can you give us a sense of the daily realities and challenges facing the communities you're working with, and just kind of help bring alive what Stephanie articulated so eloquently?
Thank you, Michelle. And today is November 1st, and we recognize Alzheimer's Awareness Month, as well as National Family Caregiver Awareness Month. We recognize that in the Black community, there are so many daily challenges to navigate that this is one more. And as Stephanie shared so much information about the challenges of this disease and comorbid diseases that are plagued in the African American community. There is also the higher incidences of blood pressure and blood sugar, diabetes, that are puts them at higher risk for this disease. And so challenging then access to care, the ability to get the proper workups when needed, starting with primary care. When a primary physician recognizes that their patient has some concerns or some numbers that are out of control, what can they do at that space to be able to assist the family? So high blood pressure numbers, what are they and how to maintain them? Blood sugar numbers, cholesterol numbers, and these numbers, again, that puts individuals at high risk. So knowing your numbers is something is really important for our community to be aware of. And where do you go when hospitals are not immediately within where you reside? So sometimes transportation is a problem, getting to the proper hospital to do a workup, or sometimes the visits may be at a local clinic where they get the basics of screenings, but need further exploration of what are some potential problems that they're having. And definitely for a full workup and diagnosis, they will have to go sometimes further than expected. So getting a legal and financial planning is something that's important, actually something that we do as we're aging, but definitely when there is a concern for a medical condition that could affect the person's ability to make decisions. Some of the important needs and that we hear a lot are the limited finances to properly care for the person who has a diagnosis or hasn't been diagnosed. And what does that mean for family, for rent, for preparing to purchase supplies that are not covered under certain health plans, and to be able to maintain health, the health of themselves, which is always at risk, the risk of a caregiver who sometimes do not have time to provide respite for themselves, time away from the caregiving role to be able to refresh themselves, then to come back with a new perspective, new energy, and continue the journey. So respite is critical. What that looks like for each family will be different. It's not necessarily having someone come in all the time to relieve you for a few hours, but to be able to take your loved one maybe to an adult day program, which allows still time for to rest from the journey of caregiving. Getting the early diagnosis is really, really critical. I receive many calls from family members who say, I see this and I see that, and other members in the family are mentioning that potentially it's Alzheimer's. We don't know. Well, then I need to educate them about not diagnosing anyone, because this is difficult to diagnose anyway, but making sure they can take their loved one to the physician to and talk about what that looks like. Are there challenges with getting there? Where do they go? So giving them the resources that they need to make sure that they understand that. Considering always stigma, there's stigma around this disease. So in a conversation, I'm listening for that. What is it that I'm hearing? Am I hearing that the person with the potential disease is exhibiting self-stigma? Is it societal stigma? And talk about that, because stigma prevents individuals, the families, from reaching out for help. So those are some things that I deal with quite often.
And Petra, do you think you could maybe, I imagine that sometimes these, all these things you're describing come together in one. You know, it's not just not having the financial wherewithal or not having the respite. It's like everything and something else. And I'm wondering, is there a particular family whose circumstances you might be able to share with us?
There is a particular family, a young man whose mother and father both has have dementia. What that means is looking at his own career as a young man. How does he navigate this role of working, building his career, and dealing with his mother and father and being overwhelmed by all of that, not knowing the progression of the disease, the stages of it, information about that. So we really try to make sure that families are educated about this disease. When they are educated about this disease and understand what's happening in the brain and the stages that are occurring, they're able to navigate with some strategies and skills to be able to handle it, all while we say to them, please take care of yourself. Self-care is critical. This is a journey that can go for many years. And some individuals that I'm aware of have been caregiving for 15 plus years. That's a long time, especially when there is no support. So what does a support system look like for an individual who has taken on the role of a caregiver? Making sure that they have support in ways that sometimes is not necessarily biological family, but for friends and neighbors, and or if you're part of a faith-based community, that they support you as well. So there are a number of opportunities to look at support systems. It takes a village to be able to handle this.
Thank you very much. Now we'll turn to Kat, who's done some exemplary reporting on these themes. Kat, your May 2023 story, A Lifetime of Racism Makes Alzheimer's More Common in Black Americans, was part of a broader AP series examining health disparities experienced by Black Americans across a lifetime. How did that larger body of reporting shape your approach or inform this story?
Yeah, so I actually have some slides to walk everyone through our process with how we reported that out. I'm just going to share my screen. Just give me one moment. So this project, which we titled From Birth to Death, was really an examination of a lifetime of health inequities that generations of Black Americans have experienced. But the genesis of it was actually, I spent a lot of reporting time covering the COVID-19 pandemic and its disparate toll on Black communities across the nation. And out of that coverage, I kind of just got a bit frustrated. I started to see a lot of coverage that was blaming just the comorbidities that Black Americans are much more likely to suffer or encounter, and not a lot of analysis, or not enough analysis, I felt, of how we got to this point. Why was this something that was able to create a perfect storm where we saw these disparate health outcomes? And so I decided to pitch a project that examined these health inequities from birth to death, like I said, that kind of really showed how this legacy of racism in our nation has really laid the foundation in many ways for much of what we have seen over decades and decades in our nation. And so we looked at it through the lens of how in maternal mortality, higher incidence of asthma, how all of these things culminated into this just issue that we've seen historically of Black Americans just dealing with these various issues. And so the first story, and you'll see why I'm talking about these different stories, is because there's a constant through line that we saw that led us to the final piece. So for this one, you have high rates of Black maternal and infant mortality rates, high rates of Black babies being born prematurely, which lays the foundation in some ways for respiratory illnesses. We talked about asthma in the second piece. The third piece, we talked about mental health challenges and struggles that Black teens and youth encounter. And this fourth story was about how Black adults have high rates of high blood pressure, and how that was one of the highest contributing factors that we saw amid the height of the COVID-19 pandemic and the deaths that we saw specifically in Black Americans. And the reason this matters is because high blood pressure is actually one of the known risk factors of Alzheimer's. So we reported this project in a way that we wanted to connect the dots and show how all of these issues compound together to create just this all of these issues, right, which can lead to the end of a Black American experiencing Alzheimer's in some cases. And so this project, we had a lot of data that focused on how could we really illuminate and show clearly what is actually happening across the nation, right? And so Stephanie kind of talked about a lot of these percentages already, but we knew that data was going to be important because this was a project that we wanted people to be at the center of, but we also knew we needed to have facts with this. And so for my reporters in the room, I just kind of wanted to talk about the methodology and thinking that we had behind it. You know, we wanted to determine what data that we needed. So in this instance, we used a lot of CDC data to determine what are the actual rates. We know that there are communities that are kind of gathering and paying attention to this on a state by state or even a more granular level. So there's a way for us as journalists to really dig into what's happening in our own communities. You know, we asked ourselves, was there any information that we needed to submit a Freedom of Information Act request for? Was this all publicly available? And in this story, most of what we got, all of what we got, frankly, was publicly available. But we also worked with other groups that were specific in this area, such as the Alzheimer's Association, who provided us with some of their own internal metrics and tracking that they've done over the years, including surveys and other things that really helped us kind of illuminate this story further. And we also kind of had to ask ourselves, you know, are we doing this data analysis ourselves, or are we going to bring someone else in? So these are kind of fundamental questions that you need to ask if you want to do reporting on this topic or other areas of health inequity. But it was also about considering how can we present this project. And if you had a chance to look at the project, I'll have some pictures later on, you'll see that we were very intentional about centering the people, centering their experiences in a way that humanized Alzheimer's. So you could see the people behind the numbers. They're not just numbers, these are actual people. And so taking that opportunity to really sit down and think of how are you going to, you know, illustrate this story was very crucial for this project. But it was also about the nuance, right? And I don't expect everyone to read through this, but the nuance is just as important as the data, right? Everyone, to some extent, knows the numbers, right? We know that Black Americans are more likely to have or suffer from Alzheimer's, but why? And there's a lot of factors, right? Of course, genetics is a major one, but a lot of the doctors that we talked to also talked about the fact that Black Americans are more likely to deal with these risk factors. And it's not just as simple as someone isn't being cautious about their diet, right? We are talking about communities that have a lack of healthy food choices, a lack of access to vegetables, a lack of the ability to they live in communities near polluting industries. These are all different things that kind of culminate into some of these issues that we're seeing. All of these things that are risk factors. But also it's about the healthcare, the quality of healthcare people do receive when they encounter or enter these healthcare systems. And the family that we featured talked to us a lot about some of the just very disturbing interactions that they had with health professionals throughout the course of their journey dealing with this disease. And it was also about making sure that we were focusing on the historical aspect of this. We wanted to make it clear that all of these health inequities were not things that just happened overnight. These were generations in the making, right? And what it really did was it allowed us to provide, again, that context and nuance that I just talked about, but it also allowed us to make these very bold and factual statements that made clear that these inequities were not new, these are generational, and that they have in large part been caused by the effects of structural racism, redlining, discrimination, segregation. And we wanted to really connect the dots and show that how that all came together. And so a lot of that was just actually going through old newspaper clips, right? This is something from, believe it or not, the 1800s that we found from the Washington Post, just talking about inequities that existed even then in the health sphere. So really allowing us to kind of detail, again, how this has been a longstanding problem in our nation. But we had one central question. Okay, we have all of this data, we have all of this information. How can we actually show this disparate toll, again, in a way that really illuminated and humanized these individuals? And it was, again, about connecting those dots. And so this was the family and that second story that we did about childhood asthma. This was the woman who lost her husband, Charles Thomas, in the fourth story. He died of COVID, and he had high blood pressure and a lot of health issues, and just a very amazing story of a father, of a man, and what his loss meant. And then we had Jessica Guthrie and Constance Guthrie, which are the family that we focused on in that last story about Alzheimer's. Jessica is her mother's caregiver. And we wanted to, for this one, show how their relationship developed over time, what that relationship was like for a mother and daughter before the Alzheimer's diagnosis happened. And Jessica told us just a very heartbreaking story of her mother, who had just this very flair for fashion. She just had this big, bold personality, but over time, she started to notice a lot of these symptoms. Her mother started to forget simple tasks. She couldn't find her way home. She eventually got into a car accident, and they were eventually able to get that diagnosis, I would say, about 7 years ago. And at the time, Jessica was living in Dallas. Her mother still lives in Virginia, and she had to pack up, move across the country, and go back home to take care of her mother. So this was also a story about how wealth, how, the inability for a Black family to create generational wealth. Jessica talked a lot about the frustrations of being that primary caregiver and the financial toll that it takes on a family, but also the emotional toll that it takes just being the only one in her family tasked with taking care of her mother. But we also wanted to show the joy, right? There's a lot of joy. She still felt that her mother was there. She may have lost her voice, but she was still able to communicate in her own special way. So throughout the course of this project, we wanted to be intentional about showing what the breadth of this journey is. It's not just about trauma, right? It's not just about their bad experiences, but what does their day-to-day look like? But it was also showing these issues that I mentioned. We highlighted several studies and research that showed that Black participants in research were 35% less likely to be diagnosed than white participants. So this is a major issue. We highlighted studies that showed Black Americans were less likely to receive dementia-related medication, which could help ease symptoms. So very serious concerns, and also the concerns of Black caregivers and the challenges that they face, their concerns being brushed aside. Jessica talked a lot about how she took her mother to the ER several times. She complained of pain, and doctors said, oh, that's just something normal that you encounter, when she knew it wasn't. So that's, again, the way that racism and bias presents itself in the medical industry. And, I really wanted to kind of end my portion with talking about equitable and representative coverage, having someone like Jessica and her mother centered in this coverage was so important for us, because we wanted to showcase these issues from their perspective in a way that wholly centered them, where they felt like they had agency to tell their story and they trusted us to tell their story. And this is reporting that's done on both the community level, but also the expert level, right? We were very intentional with not just highlighting, of course, Black families throughout the piece, but we also were intentional with highlighting Black experts, Black doctors, Black historians throughout the entire piece, because we felt that they brought an extra layer of nuance and context that we really wanted to illustrate and illuminate in this project. And, I think when you're thinking about how to do this type of reporting, it's about finding, where do these individuals exist? We have to go to them as journalists, right? Our newsrooms have historically done a terrible job of making these connections with these individuals. So we need to go to them. HBCUs, I lead on HBCUs. I develop relationships with these individuals. So really taking the time to build out relationships on an expert level, but also the community level, people that are doing the advocacy work on the ground in the communities. They have a lot of knowledge and depth that is imperative for a story of this nature. So again, just meeting people where they are, thinking outside the box, also in terms of who is rooted and steeped in these communities and who we consider to actually be experts, right? I would think someone that's been advocating for Alzheimer's for 20 years in their individual community is as much of the expert as someone that, is on a collegiate level, right? It's just a different type of expert. And, I also want to end with, when you're going through this process, one thing that I wanted to note about Jessica is we spent a lot of time with her mother. Before we even went to their home, we had many, many conversations laying out what this process was going to be like, what the story was going to be about, answering their questions, explaining that, at the APR stories go everywhere. So you might get different types of comments that make you uncomfortable. So really just explaining the total process, because most people don't understand how journalism works. And I just think when you're dealing with communities that have been harmed or underserved by journalism, it's very important to make sure that we're clear with how this process works. And what I want to end with is Jessica, when the story published, I was very, very nervous about her reaction. She has quite a following on Instagram, and she shared this about how the series was illuminating, and she felt seen, she felt heard. And for me, that is what this work is all about, giving us the opportunity to shed light on these inequities and highlight the voices of people who for a very long time have not been featured in our journalism. And I'll end there.
Thank you so much. What a really helpful presentation in so many ways. And I want to thank Stephanie and Petra as well. We're going to open this up to everyone's questions, but maybe Stephanie, did you want to quickly pop up your map before that? I think we would all love to see that. You're muted, Stephanie.
Thank you. I will pop up just a static statewide visualization of the map, if this works. Can people see it?
Yes.
Okay. So this is just showing Alzheimer's disease prevalence by state. Obviously, the darker states have the higher prevalence of Alzheimer's disease, as indicated over here. These numbers and percentages are based on data that we get from the Center for Medicaid and Medicare Services. This is fee-for-service data. We're actually in the process of getting data that will show Medicare Advantage, and the numbers will change a bit. But with the tool that we have, which has not gone completely public yet, we hope to be able to launch it for more public access before the end of the year. Actually, and importantly, is able to go down to a zip code level to show people where these high prevalence of Alzheimer's disease and other dementias are in their states and hot pockets. So just because California is not hot red, when we pulled up, like if I did a county-wide map, you would see there's lots of spots where there are very clear pockets of high prevalence in Alzheimer's disease. Also, our map allows people to look at, for example, if people, because people over the age of 65 aren't going to come into a healthcare system just presenting with Alzheimer's disease. And so what does that look like? And so we're able to say, for example, if you have Alzheimer's disease and also diabetes, your Alzheimer's cost per patient is about $31,000. If you add diabetes to that, the cost per patient goes up to over $40,000. How much could we be saving as a nation if we actually could address diabetes, things that are controllable, modifiable risk factors? And in terms of, and what would that look like? How many more schools, how many more health centers, how many more individuals could we employ, and how much child poverty could be reduced if as a nation we were really committed more to preventing diseases such as Alzheimer's disease? We just added last year an important sixth goal to the National Alzheimer's strategy, which is to really focus attention on prevention, which is really important for communities. Over here, I think very interestingly, we have all the states by the prevalence of Alzheimer's disease. So we see that Florida is the state with the highest prevalence of Alzheimer's disease. And if the state has a blue line, that means they have an Alzheimer's disease research center, which is a specialty center that focuses on Alzheimer's research, finding better treatments and hopefully cures. funded by the National Institutes on Health, specifically National Institute on Aging. But all of the red states do not have an Alzheimer's disease center. And so when we talk about people being able to access specialty services, cutting-edge treatments, even, good opportunities for diagnosis, of course, we can go, to hospitals, and there are wonderful academic centers throughout the country. But this is one of those structural challenges that we need to make sure that we have Alzheimer's specialty centers in places where people are, and that we are really leveraging our entire healthcare system to make sure people, don't have to travel 200 miles to find a neurologist, if there are even one that's there, that they can find them in their neighborhoods. Whether they are at an academic site, and most of these are academic sites that we're seeing, and all the reds, of course, there isn't one. Whether they are federally qualified health centers, others who are there. We've got to be really intentional about building this infrastructure, because what we're seeing, which is exciting, with the new treatments that are coming on, they're responding to the idea that you could have pathology beginning in your brain for Alzheimer's disease 20 years before you start experiencing the first symptoms. And so if people can get in early, and we can begin to see this pathology earlier, there are medications now that are coming to market that will allow us to slow the progression and hopefully prevent it and hopefully cure it. But we need to have that kind of a commitment to research. When we began working on this in 2010, the National Institute on Health budget for Alzheimer's research was about $400 million, which is really shameful when you think about this cost, like $2.7 billion, and we're paying, $400 million. But we've now thankfully been able to work collaboratively, nationally, state, locally, and Congress has been responsive, and we now have a budget over $4 billion a year. And so that's what has allowed us to see some of these really innovative and exciting changes. However, one of the big challenges that remains is that we don't see minorities being included in research. So even with the medications that just came to market, again, with Blacks being 13% of the population and 20% of people with Alzheimer's, we had 3% of Blacks represented in the clinical trials for these drugs that are coming to market. Did a little bit better with the Latino population, I think they had about 17% there. Asian Americans come in at about 3% in terms of clinical trials. And so if we want to make sure that medications, treatments, even the way we diagnose works for everyone, everyone needs to be included. We are very close to becoming a 50-50 minority-majority population in the United States. And we can't have clinical trials with 93% whites in those. So we do have significant challenges and barriers to make sure that we are building for equity, or else we are building disparities.
Thank you, Stephanie. This is really helpful. Two quick questions before we go on to our next question or two. That cost per patient, is that meant to be an annual number? I'm thinking about your $15,000 a year, a month for your father's care, or is that—
These are medical costs. These are medical costs only here.
Is that
the cost per patient? Actually, the cost nationally in terms of Alzheimer's disease, when we include all of that, is closer to, last time I checked, it was closer to 17 billion national.
And then we have a question from John Funabiki from San Francisco State asking where we could find this data online.
It's not available yet online, but if people want to reach out to me at smonroe@usagainst-alzheimers.org, I'm happy to give you some access or run some reports for you if you have a particular state in mind that you would be interested in learning more about.
Thank you. So I'm going to go to some of our other questions. We have a question from Bart, and I hope I'm pronouncing your name correctly, Fankuch, who says, great presentation. Is there a disparity or disproportionate level of Alzheimer's in Native American communities or on Indian reservations?
Yes, very significantly. Again, we are not seeing minoritized populations being included in research. When we're seeing them we know about 40% of African Americans who have Alzheimer's disease are not receiving a diagnosis. And so, yes, we absolutely see that. There's a different healthcare system, as you know, Indian healthcare system, and Indian country is a separate sovereigns who have the ability to share data with us, and sometimes they do that, and sometimes they do not, as is their right as a separate sovereign nation with treaties. And so we're learning more. The Centers for Disease Control has created a roadmap specifically for Indian country. And so I would recommend that if you're interested in those issues, that you would go to the Centers for Disease Control website and look up the Alzheimer's roadmap for Indian country to learn more about what we know about our Native American brothers and sisters and what needs to happen to get them on par and bring equality into those important communities.
A similar question from VG Sundaram, who asks, what percentage of Asians are diagnosed with Alzheimer's? And I'll just add, there's so many different Asian subgroups that have different prevalences of some of the other diseases that you identified as risk factors. Are there ways to get that kind of data too?
Yes. And actually, I had answered in the chat, and I think I answered incorrectly. I know that only about 3% are included in clinical research. So it again appears the numbers are very low. Generally, we don't find the kind of health disparities with Asian Americans as we have with the African American and Latino populations. But happy to dig a little bit deeper into that to see what we do know. Obviously, we want to look with Asian Americans and Asian populations globally to see what's happening internationally. And all of our work that we do here, certainly at Us Against Alzheimer's, is also working to look at and respond to global crises that we have worldwide.
Erica Hensley has a question for Petra. She asks, how much is late diagnosis impacted by geriatrician shortages?
It's heavily impacted. It's also the lack of understanding of what the basic signs or symptoms are, and some wanting to wait for a dismissal as also I'm not sure that Alzheimer's is not a normal part of aging, and so I'm expecting that, well, they're older and this is what will happen. I spoke recently with a neuropsychologist who says that in her 5 years of working, she's kind of newer to this, that she has not been able to diagnose an African American in early stage at the very beginning. She has only been diagnosing those who are at mid to later stage. So this is a challenge that we have. Again, there are some risk factors that you see at the primary care level, and that is such a telltale sign of physicians working to connect with the specialists to then be able to make sure that the proper diagnosis happens at a really early stage. It impacts making decisions and so on, life decisions.
I was just going to add one note too, that, some of the researchers that we interviewed for the project talked about how referral bias or differences in diagnostic thresholds being applied to Black Americans. That's also a concern that a lot of people have. Are they just being treated differently and not being taken to that next stage where they're being referred out for the necessary testing? So that kind of goes back again to the bias in healthcare and some of the aspects and how that shows up in a specific round too.
Yeah. And Kat, just to follow up on that, your story has a number of really disturbing examples of health providers ignoring what the Guthrie family was telling them. And those that did listen, as you noted, seemed to be Black. So what do we take from these instances when it comes to medical training or workforce diversity, or there are other health systems takeaways that you might have?
Yeah, I think one crucial thing that we saw throughout the entire project was the need to have a more diverse workforce of doctors and healthcare providers. That's one aspect of the solution, right? But then the other piece of that is, the burden cannot be placed on providers of color alone, right? So it's about how do you transform a health system that needs to deal with these bias issues or outright discrimination issues that many Black Americans and other people of color have described. But we are seeing different schools, medical schools, and other groups try to really affect that pipeline and identify new talent to bring into the workforce.
Yeah. And just looking through this, Glenn Ellis says, I'm grateful to the important work you're all doing. How important is it to be clinically diagnosed, and how does that process work?
I can take that on. It's absolutely essential because, as I said earlier, when you you may begin having symptoms of Alzheimer's disease, or say, that it's sort of running in your family. We're not necessarily seeing genetic condition. It may run in the family, but it may not be running because of genetic predisposition, but because of those shared nutrition and habits and where you live and things of that nature. So we don't necessarily know sort of why we see it running in families. When you begin to have or see a loved one experience things that are of a concern, like I said, if there are issues that are impacting your activities of daily living, not the, oh gosh, I don't know why I came in this room, or where did I put my keys? But if you see someone who's putting a key in a refrigerator or doing something they can't remember, they used to go to church every week and they can't remember exactly how to get there. Things like that might make the person feel a little bit uncomfortable. Those should be taken seriously and asked, because like I said, there's other medical conditions that could cause those types of symptoms, like UTIs, like medication interactions. And so you want to rule out those other things that are really reversible, and then allow your primary care physician to just sort of do a little bit of checkup from the neck up, as we say. I would say, get a baseline before you're 65. 65 people who are on Medicare are able to get a welcome to Medicare visit that does include some cognitive testing, but you may begin to see some changes of concern, and really see the doctor just to make sure that what you're seeing is normal, is something that might be treatable because of another condition, or if there's additional concern, that you get that additional test, because these new medications and others work most effectively early on. So it's really important.
Yeah, thank you. And we have a question sort of in the same territory from Sunita Surabji from Ethnic Media Services, who asks, at what point in the progression of Alzheimer's does a person need care? Can they still significantly participate in the workforce during the initial stages? And do Black Americans experience Alzheimer's at an earlier age than the population at large?
I can answer, but Peter, you may want to, so I'll defer.
Thank you, Stephanie. The ages are really interesting, again, because it goes back to dismissal. And when you're bringing up concerns to your physician and you're told, well, don't worry about that. You have a lot of stress. So, go back and do what you're doing. There are some very particular signs or symptoms that should bring concern, and that is when you are not being able to handle your finances, not able to balance a checkbook or online transitions, however you're doing it, not able to pay your bills or you're paying them over and over, or they're stacking up. It's also the repeating of questions and stories because you don't remember that you've already done that. And these are really some alerts for that. It's important to also consider that in the African American community, again, stigma, the dismissal of certain conditions, or, well, that's normal, you're just excusing it, and not in a negative way, but that's just handling it the best way possible to be able to say, I'm tired, I worked so hard this week, I know I forgot to do this, but it's just because I'm really, really tired and I just can't get to that. And then thinking about it, and also within the community, who says what to whom? How do you as a family member and or a friend share information that you've seen exhibited in the behavior of someone you know? These are very difficult and delicate conversations to be had. And how do you do that? Driving with a friend and you recognize that they're not following the rules of the road, and or they got confused in the conversation and didn't quite respond in the way that was expected. So there are a lot of signs and a lot of things that come up, and sometimes hindsight and individuals say, oh, I did see that happening before. In the early stage, individuals should still be able to dress themselves, prepare lunch, drive, and be able to function somewhat. It is after that stage where more assistance is needed that they're definitely have to get some additional support. But the stages, this is a progressive disease, stages will change, and when that happens for each person is different. There is no guaranteed after 6 months the person's going to transition to another stage. It's complicated, and stages are not perfect. People fluctuate between stages.
Kat, I want to turn to you. You had talked in your presentation about ways that you really work to show respect for your key protagonists. And how do you go about winning that trust and keeping it in just an intimate and really difficult moment?
Yeah, that was a major part of the project pitch that I had to my editors, was that I said we needed time to source, develop, to cultivate trust. And so we spent months, a lot of the initial work meant just trying to find the right voices. So that was us scouring social media, reaching out to different advocacy groups on the ground to find people who they felt would be a good fit for the story, who would be comfortable. But also, for me personally, I wanted to do this in a way where it didn't feel as if we were being intrusive into this family's life. We were just trying to illuminate their story, but we didn't want to add to any heartache or anything that they were experiencing. So with Jessica, we actually found them via social media. We reached out to Jessica, talked her through what we were hoping to accomplish, going back to those earlier slides, just really detailing how the AP worked, what were our expectations, what did we need, but also giving her space to ask us questions, or giving her space to illuminate the frustrations that she had with some of the coverage that she's just seen across the board. So it was really just about treating them how you or I would want to be treated, right? Treating them how they deserve to be treated, and allowing, again, that humanity to be the center of the storytelling, I think, was one key aspect in terms of how we were able to really develop their trust, and just also existing in their space too. There are times where we didn't even ask questions. We just allowed them to be. We were just observing, and I think they just really appreciated us wanting to truly just understand what their lives were like.
And did you, just a quick follow-up, did you give people the option, not just for the Alzheimer's stories, but across your series, to change their mind about whether they want to be on the record and those sorts of things that typically, a big news organization like AP might not be as tolerant of? I mean, did you have to sort of set some rules almost with your own editors as you embarked on this?
Yeah, there was a lot of conversation about what do we do if someone at any point decides to pull out. And actually, for this story, there was another family that we made a connection with that I started the interview process, but then her mother took a turn and she just couldn't do it. And, as journalists, of course we want a story, but this is their life and journey and experience, and we were not going to force them to allow us into their lives, right? When people trust us with their stories, it's really a gift. So we just retooled. And I think, you know, when you do a project of this nature, you kind of have to go with the flow of it and understand that that might happen, but that's okay, because there are other ways to tell these stories. But with Jessica, you know, the lead of the story, we talk about how she was prepping essentially for her mother's funeral, and how she didn't know how much time her mother had left. And that was a big challenge for us because we didn't know how this was going to turn out. And we were in constant communication with her just to let her know if something happened, she's going to the hospital, just let us know. We could work around this and figure this out. So again, it was just about being in that constant communication with the families throughout the series, which took over a year to do.
Thank you, Kat. And we have run out of time, but there's still a lot of questions. So maybe we'll just take another couple with all of your patience. We have one question from Anne Hubin Kearney, who says, and I think this is referring to you, Peter, you talked about stigma. What can we do to help the caregivers and individuals reduce the stigma similar to mental health?
Thank you for that question. And as Kat was sharing in her story, the need for journalists to balance the good with the bad, and her showing the burden, but yet showing the blessings of caregiving. And so the words and the terms that are used in information is so powerful. And also the sharing of information is overwhelming. You have to think about who your audience is, the words that are used, the sharing of statistics, even that I found has been really overwhelming to those who are receiving the message. It is like a paralyzing kind of effect. And sharing statistics, it kind of infuses fear almost. As someone who has to present statistics myself, I am always trying to connect with the audience. How did that statistic just land on them and their ability to move that forward and have fear because of, or do they want to go on in the conversation, or no, we need to stop. That was just really hard to hear. Where do we go from here with that? So the power of sharing information, balancing words, leaving hope, in other words, giving hope, sharing information that educates the community and yet leaves them with, all right, they told us this, and there are some resources, at least 2 or 3. Now I know where I can move forward with this. I wasn't thinking that I could reach out, but now I'm going to reach out because that information is there and it's free of cost and it's not a concern for travel or anything. I should reach out. So it helps. Stigma has to be reduced because, again, it prevents individuals from reaching out. It's not only, so we're dealing with self-stigma, the person that potentially has the deal, so societal stigma, institutional stigma, all of these affect the ability for individuals to reach out and get help.
And if I could just briefly add to that, I think we've seen a great transition from people who felt certainly 10 years ago much more stigmatized than they do today. And one of the things that was different, frankly, were reporters writing stories, were people being willing to come out of the shadows and admit that they had this thing going on. Whether it was someone like, B. Smith, very well-known Black entertainer, person of influence, our version of B. Smith, our version of
Martha
Stewart, yeah. And people being willing to talk about their disease and us not saying, making them feel as if they are the disease, right? They're individuals who are living with a condition. They are not Alzheimer's disease. They have some limitations, as we all do, but they have a lot of other things that they can do. And we can see, in fact, people gain new abilities. You know, you see people who have never been able to paint, they get Alzheimer's disease, all of a sudden their brain allows them to become a painter. So things like that, that changes, and, you know, that we love our loved ones who are changing in front of us as we all change, as we age, as the youth grow up, and accepting it, not always looking to the past about what you've lost, but about, you know, how this person has changed, how they've become more loving potentially, and just really embracing it. But I think giving people permission to really talk about it. I'd also recommend, there's a reporter who you all may be aware, named Greg O'Brien. He has developed Alzheimer's disease and has continued his writing. He has a book called On Pluto, and a documentary. And it's wonderful hearing a reporter write as if he's like interviewing himself. So just, you know, looking for those stories of people who have influence and just regular people, and giving them permission to talk about how they're feeling, you know, demystifying the disease. Like we did, you know, so many years ago when you couldn't say cancer, it was the C word, right? We don't want to make people feel that they have to go into a closet because they're experiencing a disease that might be some changes to their brain. So welcoming those conversations.
These insights are so wonderful. I'm going to see if we could call on your forbearance and try and squeeze in just one or two more questions. Carlos Ballesteros says, could you talk about dementia, Alzheimer's in prisons? You know of any states handling this issue better than others? The prison population is aging more rapidly than the general population.
Yes, I could speak to that. California has a program, and there is actually a book that is a model for prisons around the nation. And there was a program called Within the Prison, where those who were on good behavior, et cetera, chosen, allowed to care for lifers. And these individuals were trained by an Alzheimer's Association group, and they were trained as caregivers and trained to take care of the individuals with a diagnosis to end of life. So they were also trained on palliative care and hospice. These individuals were called the Gold Coats, GOLDCOATS. And if you Google that, you'll see their story. It's amazing. I've met some of them. They are amazing men who happen to have gone to prison for some not so challenging ideas, but sometimes if you're crimes, if you're in the wrong place at the wrong time, there you are. But there are individuals whose recidivism rate is 0, who have been trained on this disease in amazing ways. And again, there's a Gold Coats book as well that you can Google that. But we do have a community of people, men and women, who are aging in prison. And the ability of the Gold Coats to go in and out of a cell, to be able to handle the issues of the person who needs the care, it's the most amazing thing. So take a look at that.
And our final question is from Cassie Chu. She says, is there any data on early onset dementia among people of color?
I have not come across any.
Yeah, to be honest, I would say the same thing. I was hoping, Peter, that you had a good response. I'm sure there is. I'm just not as familiar. Again, we don't have the data we need because we need people to be volunteering more, and we need to, you know, both understand why there is a reluctance for the Black population in particular to participate in research because of past and ongoing missteps, atrocities. These communities, our communities, really want to understand how the data is going to be used. They want to have the data reported back to them. And it's, you know, I think many institutions are working to develop that, but many are not there yet. And so there is a reluctance. But I will say this, one of the biggest hurdles for minorities to engage in clinical research or studies and surveys and all of that is that they're not being asked. We're being asked about surveys. We're not being asked to participate in research. Again, many times because of a bias, because of the shame that the medical system has in knowing what they've done and not wanting people to say no, because of a bias thinking, oh, it's going to cost so much more money for us to reach out to these communities and all of that. But we have found that there are certain organizations, the Global Alzheimer's Platform, for example, has done an excellent job at recruiting over 20% of people in their clinical research, which is wonderful, considering, I guess, the national average is between 3 and 5. So when they do and go into communities first, listening and asking what the community wants and needs before you ask them to give you what you want. I mean, there's a whole strategy for how to win over the trust. But we've got to be very intentional about that. We need regulators to be really intentional about how they allow clinical trials to proceed and drugs to come to the market with such low numbers that we don't know until that drug has come to the market, whether it's really going to be safe and effective. We need to work, academic centers and others really work to be part of the community, not just having a zip code located in. And this needs to be sustainable, not helicoptered in when something is wanted and then they leave. So there's a whole strategy that has been working, we're implemented, but we need much more interest and dedication. And I would say, I think we're going to see these numbers change because just recently, last year, the FDA, Food and Drug Administration, is requiring now companies and others to actually put forth, what is your recruitment strategy? How are you going to bring diversity into your trials? What are specific things that you're going to do in communities to work with those communities? How are you going to make sure that patients feel that they have received at least a reimbursement for their expenses and the time that it takes to participate in research? So we do see some headway, policymakers really understanding the importance as we go into a 50-50 majority minority, that we are doing medications and strategies and eliminate these health disparities because it absolutely has to happen.
Well, I want to thank all three of you, Stephanie, Petra, and Kat, and to the audience for all of your great questions. I also want to thank the team working behind the scenes to produce this webinar, content editor Ryan White, communication strategist Apps Mandar Vishu, community engagement editor Cassandra Garibay, program specialist Andrew Perez, and contributing editor Fran Smith. We'll be sending you a survey asking for your feedback on today's program and for your ideas and other topics of interest. Please take a moment to complete it and let us know if this program influenced your reporting. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. If you would like to help contribute to this webinar series, here's the information on how to do that. Thank you so much for joining us and have a wonderful day.